Morning, good afternoon. Thanks WHO for invitation, uh, for sharing our experience from Thailand in the WHO first Infodemic Manager training. I will represent all Thai partners. Will present the topic on science-based risk communication and managing infodemic and how Thailand responds to COVID-19. These are the 5 outlines. First, I'd like to update you on COVID-19 situation in Thailand since the beginning of epidemic. We have the first case on 13 January this year. And then we officially declare through the Communicable Disease Act that COVID is a dangerous communicable diseases. There was a peak of epidemic in March. That peak uh, were attributed by a number of super spread from boxing theater and from entertainment venues where there are big social gathering, and that super spreader has spread from Bangkok to other countries. Curfew was introduced on the 3rd of April between 10 p.m. and 4 a.m. in order to prevent social gathering in pub, in bars, in restaurants. That was introduced after 26 March that we declare state of emergency, for which many countries also introduced state of emergency. Um, Situation has been improving in the first in by the end of April this year. The peak has gone down and we can contain the first wave. And there was no local transmission since 25th of May 2020. All the subsequent infections are from international travelers, either Thai or non-Thai, and they were all detected in the state quarantine, as the government has introduced 14 days mandatory state quarantine. And after 25th of May, we do not have local transmission. And the total case as of today, middle of November, we have less than 4,000 and only 60 deaths since the beginning of the pandemic. What are the risk communication system in Thailand? It is the whole of government through Center for COVID-19 Situation Administration, CCSA, which is led by Prime Minister. And the Prime Minister also authorized all the provincial governor. We have 77 provinces, including Bangkok. Therefore, the governor is the um, responsible person in their constituency. He led the provincial communicable disease committee, and the chief medical officer in the provincial chief medical officer is the secretary of the provincial disease control committee. The second characteristic is one voice through live TV daily briefing as an official source of information and delivered by CCSA's speaker. You see Dr. Tavisin Visnu Yothin, the spokesperson of the CCSA, and he became an icon of daily situation update, televised in all media every day since the beginning until today and yesterday. The third attribute is science-based. It is the transparent, evidence-based, and easy to understand message. And all the guideline information are distributed to ensure citizen trust and adherence to public health and social intervention. The last attribute is multi-sectoral collaboration. Through the whole of government, um, with within government department and non-government actors, the private sectors, the tourist industry sector, etc. This is to amplify the message and reach the broader audience throughout the country, in particular the media constituency, the public media. This is a schematic of the governance, the mechanism. The CCSA consists of all the ministries. The green bubble is the Ministry of Health, for which the WHO work closely with the MOH. MOH is part of the key partners of the CCSA. Within the health constituency, we have many actors, many departments in and outside the MOH. The Ministry of Health established Emergency Operating Center, for which it meets almost every day during the peak, and today, this week, when the peak has gone down, then they met 3 times a week. On the brown bubble, we have Ministry of Digital and Economy, for which they have Anti-Fake News Center, which is equivalent to a department of that ministry. Also do the fact check and manage the infodemic. As you see, that there's the national spokesperson, which is Dr. Vishnu Yothin, is the speaker on behalf of the CCSA on a daily TV nationwide televised to the health workers, to the governors, to general public, and through media and news agency, further generate information which is local context, dialect specific to the general population. On communication for citizens adherent to public health and social intervention. These are the government interventions so far. This includes public health and social intervention, for example, test, trace, and mandatory 14-day quarantine, and treat all affected patients free of cost, both Thai and non-Thai. Government advocates stay-at-home policy, and from limited to full travel restriction at the peak of epidemic in March. So there's a total lockdown throughout the country that you can only travel when there is a reasons, essential reasons. Government also advocate personal protection behavior, which include 5 domains. Face mask, though it is not mandatory, the adherence was very high. Hand hygiene, using soap or alcohol hand rub gel. Refrain from touching eyes, nose, and mouth to prevent infection. Physical distancing of more than 2 meters. And food hygiene by not sharing the utensils, because from the pub and restaurant, they share the same drink, same straw, and they smoke the same cigarette. So that's why they are infected. So these are the 5 personal protection behavior that the government has advocated. Government also introduced protocol for all public services during the unlocking phase. For example, convenience store, coffee shop, market, restaurant, and school. This includes mandatory face masks by providers and customer, and restriction number of customer in restaurant and and many others, such as department store. A mandatory thermoscan, hand hygiene, register Thai Chana application for future contact tracing by all customer. You see, I have a green dot here. That means I was scanned, thermoscan this morning, coming to MOH, which is the office of IHPP. So that is continued practice since day one. So mandatory thermoscan in all public spaces. In particular, when you're going to a hospital, you have mandatory thermoscan. everyone. If you have fever, you are not allowed to enter to the public buildings. This is Thai China application for which the government has launched since May 17, when we start to unlock. Therefore, we have to monitor. Should be able to monitor if there is unfortunate a case, so that we can do contact tracing. Thai China is managed by Department of Disease Control in the MOH. This means all shops require customer to check in and check out by scanning QR code to register with Thai China application. In the application, data consists of name and mobile number for future contact tracing, and this has proved very useful in Rayong province when we have two international traveler non-Thai who travel to Rayong, and they went to department store, and they walk around in the condominium, etc., without adherent to quarantine requirement. Then we use Thai China, and we can contact more than 4,000 of them and test those who are closely contact with those confirmed cases. IHPP and partners has introduced online surveys. This online survey, I would say that it is informed policy, evidence-informed policy on citizen adherence. In April, we have a weekly online Google platform. May, June, and July, 3 months, we have weekly online surveys using 3 platforms. First, the Google platform, which is more or less dominated by the highly educated and civil servant and private sector employee, and less farmers and other lower educated people. The second platform is telephone survey platform. And third platform, citizen reach out by village health volunteer platform. This mitigate the bias of the Google survey platform. And we are so satisfied with that. Citizen reach out by VHV platform is the best because their socioeconomic profile represent general population in Thailand. That's why in August, September, October, and November, 4 months, we have a fortnight online survey. And using only one platform, which is the Citizen Reach Out by VHV platform. And we have planned, because the EOC and CCSA has mandated IHPP to continue to conduct survey in December this year until December next year through a monthly survey, less frequent. The key content in online survey and future online survey, we have a standing module in all survey, including personal protection behavior, travel outside province, and social gathering. And additional module include other policy relevant topical areas. The survey finding form specific content of risk communication with the citizen through the CCSA. I would say that this is an iterative route between government intervention, assessment of citizen practice, informed policy, and strengthen effectiveness of the government intervention. So there's a here back arrow from general public to inform the CCSA through online survey in this organogram. These are the findings of citizen adherence to government measure. On the top line is the self-protection, which is the 5 behavior as I have said. In May, the composite index of these 5 behaviors was 85.3% and was maintained at 80% until June, July, and has gone down slightly to 79%. in late of July. The survey period between 15 May and 31st of July, we have a big respondent up to 470,000 samples. On social gathering, after May, there were no local transmission. There is a trend of increasing social gathering from 24.9% in May-June to 43% in July. And also travel to other provinces has slightly increased from 17.7% in May-June to 24.8% in late July, because the government start to ease travel and relax the social gathering on the condition that you have to keep wearing face mask all the time in public. These are the Thai Chana QR code. In one of our survey during 17 to 31st July, there was 63,000 respondents. We asked them, have you ever not registered with Thai Chana platform or application? 22.3% report, yes, I forgot to register. And 27% said they forgot and they cannot see QR code or register book. It's not available, 25%. So this evidence is very useful to strengthen the adherence to registration of Thai Chana and enforcement of all public service provider that you have to have a Thai Chana facility for all customers. What about Infodemic Management? We have a peak of monthly confirmed case in March, 2,123 cases. At the same time, a peak of number fake news up to 151 message, and has gone down when the case has been subsided and we can contain the first wave of the epidemic. Thailand has capacity on fact check, both using the Thai partners and international partners. The Anti-Fake News Center by the Ministry of Digital Economy and Society, they have conducted 184 fact check in the month of March during the peak of epidemic. And also COFAC, which is a civil society organization, they have conducted 84 verification. And all this information were useful for IHPP conducting 8-week infodemic survey. And also Sure Before Share, which is a media agency by a TV channel. They work in collaboration with academic and expert on fact check, and they have conducted 46 verification. Note that there was more than 1 million media message per month during the peak of pandemic. Apart from national capacities on fact check, we also use AFP. We also use division Mythbuster and use a lot of zero fact and fiction website. So 38 verification and 29 verification are very useful for our amplification of what are fake and what are true message. These are a few examples of fake news in Thailand during the pandemic in April. Example, fake news. On infodemic management, we have two goals. One is to monitor citizen behaviors and attitude and evaluate risk communication system. This was conducted by IHPP and Ministry of Digital Economy and Society and also Thai Health Foundation. We have a 10 weekly online survey. The first 8 weekly survey was to assess the citizen media literacies. And the last 2 weeks is to assess the risk communication system. On media literacy, we compute media literacy index, which is a composite index of two small sub-index. One is capacity to differentiate misinformation, true and false statement, and not to propagate or sharing false statement. This was conducted between 4 May and 25th of June 2020, and we have 52,000 respondents in this 8-weekly survey. On assessment of risk communication system, it was conducted 2 weeks between 26th of May and 9 July, for which we have 15,000 total respondents. And this was supported by WHO country office. Thanks to WR, Dr. Daniel, for his continued support. This 10 weekly online survey, we found that misinformation is everywhere. It distributes nationwide to different socio-demographic groups, which can hinder the effective control of COVID. Our respondents, 82% said they have seen misinformation and disinformation in social media during the last month. And we compute media literacy index of 69%. 69% is geometric mean of 54% of citizens who can differentiate false and misleading information related to COVID. And 87% did not share false or misleading statements in other social media. Our study also found that the higher educated, the female and older age group have higher media literacy index, though young adults do not further share fake news. Also, 42% of respondents verify facts and mostly from public sources. What are the conclusions and policy recommendations? From the review of our experience so far, we'd like to conclude that the critical attributes on risk communication are single command system, scientific-based message, and iterative loop between online survey findings from citizens and specific policy implementation by CCSA and MOH. The critical attribute for effective managing infodemic are sustained national fact-check capacity, and we need reliable government verification sources, authentic source from different ministry, in particular from the MOH. We need to raise public awareness on the misinformation, disseminate scientific evidence from authentic source, for example, the visual in local language. So this is to counteract with misinformation. Further, we need effective and timely legal sanction on individuals who produce misinformation, and also advocate public not to propagate misinformation in social media. A few policy recommendations on effective risk communication. We have to ensure citizen adherence to public health and social measures. This was done very well through the function of CCSA to transparent evidence that gain citizen trust and adherence to public health measures. As you have seen that the personal prevention behavior index was very high. Even in the unlocking situation, we have 78% index. On message to vulnerable population, this is a gap for which we have filled the gap. It must be tailored content and multilingual and linguistic friendly through the whole of society support. We have used Myanmar, Lao, Bahasa, as well as Cambodian language in many media platforms. We have a huge number of migrant health volunteers who play a significant role because we have 4 million migrant workers who cannot understand Thai. Therefore, we have linguistic friendly service for them. Finally, we recommend that legal framework and fact check and law enforcement is important in combating misinformation and disinformation. This is still limit capacity on, we have still limited capacity on fact check. The major pain point is inadequate and timely legal sanction, especially cross-border misinformation and lack of public participation on fact check. I'd like to thank the WHO and partners who champion risk communication and provide guidelines on RCCE, risk communication and community engagement and managing infodemic. Thank you so much.